Welcome to this webinar on long-term outcome after upper airway surgery. My name is Pullens. I'm ENT surgeon from the Erasmus Medical Center in Rotterdam. This is a modified version of a presentation that I did with the same title at the Rome ERN meeting in November 2019. The topic of this presentation is outcome after airway surgery, and by airway surgery I mean surgery for a laryngotracheal stenosis. In this disease there is a stenosis at the level of the glottis or the subglottis, and this stenosis is usually caused by prolonged intubation and scarring, but in a small number of patients it is part of a congenital disease. Severity of complaints is usually dependent on the degree of airway stenosis. In more severe cases, a tracheostomy is needed for adequate ventilation. Now, in our hospital, we have been doing open airway surgery for laryngotracheal stenosis since the 1990s. And basically, there are two major operations that you can do. One is a laryngotracheal reconstruction, where you use the patient's own cartilage to enlarge the airway, and another is a resection where you resect and take out the stenotic airway, after which you need an airway anastomosis. And also in recent years, endoscopic surgery has gained popularity with the development of more sophisticated tools such as sophisticated lasers and dilatation balloons for the airway. Now, when you look at the current literature, outcome of surgery for laryngotracheal stenosis is usually determined by the decannulation rate, and with that I mean the number of patients who are relieved of their tracheal cannulas after surgery. Now, this is of course a very important measure and very important for the patients, but it's also a very rough measure for airway patency, and it also is a short-term outcome measure. If you look at the results, the decannulation rates in the literature and in our own series, they are very good. Decannulation rate after primary surgery in our series is 93%, and after revision surgery is 95%. However, this does not give you any information on long-term outcome, and in the current literature there is very little long-term outcome reported. This is surprising, since most children are operated on at a very young age, and the mean age of surgery in our own series was 2 to 3 years. So it would be very interesting to see how the outcome is after these types of surgeries at different ages as the child is growing. This was the reason why we started our long-term outcome project in 2015. What we did is we invited all children who received open airway surgery in the past for laryngotracheal stenosis to come into the outpatient clinic. In total, we could include 65 children for this study, and mean follow-up time was 7 years after surgery. And these patients are always characterized by a high degree of comorbidities, and in our series the comorbidities existed in 55% of patients, most of whom had bronchopulmonary disease after being born preterm. So at the outpatient clinic we assessed outcome on 3 levels: a functional level, a quality of life, and quality of voice. For the functional outcome we used pulmonary function test, and within the pulmonary function test we used a flow volume curve, which gives you numerical values of the airflow through the airway. We found below normal values on pulmonary function test in more than half of patients, most of whom presented with a mostly inspiratory obstruction, and that points to a residual airway stenosis. We did some analysis on these results, and we found that the patients with poorer outcome on functional level were the ones with glottic stenosis, so scarring at the level of the vocal cords, and the patients with comorbidities. When we look at the quality of life, we used the Child Health Questionnaire for parents and for children to assess quality of life. And we found that when asking parents about the quality of life of their children, they reported worse quality of life for their children when compared to peers on several subscales. What was striking was when we asked the older children on their own experienced quality of life, we did find worse quality of life on physical functioning, but to our surprise found a better quality of life on mental health when compared to healthy peers. From our own clinical experience, we already knew that these patients with laryngotracheal stenosis and the patients that received surgery for laryngotracheal stenosis all have severe voice complaints. And that is exactly what we found. Over 75% of patients at long-term follow-up, we found substantial voice deficits with high impacts on quality of life. We also did a sub-analysis on this group, and we found that especially the group with severe glottic stenosis before surgery and the group with comorbidities had worse voice-related quality of life at time of follow-up. So in conclusion of our 2015 research, we found that at long-term follow-up after treatment for laryngotracheal stenosis, after being decannulated, we still found deficits in quality of life, voice outcome, and pulmonary function test at long-term follow-up. The patients with poorer results were the ones with multiple comorbidities and glottic involvement of the airway stenosis. And in our opinion, this is a clear indication that a long-term multidisciplinary follow-up is essential in children who are treated for laryngotracheal stenosis at an early age and after successful decannulation. So after analysis of the results of our research, we started to incorporate a standardized follow-up program in our airway outpatient clinic, which is multidisciplinary. And we see children at this outpatient clinic at different ages, different times, at age 2 to 3 years, 5 to 6 years, 9 years, 12 years, and 16 years. The multidisciplinary team at this outpatient clinic is of course dependent on the need of the child in question. The members usually consist of the ENT airway surgeon, pediatric intensivist, speech and swallow therapist, a specialized nurse, a pediatric pulmonologist, a pediatric surgeon, a cardiothoracic surgeon, or gastroenterologist when applicable. We try to organize the outpatient clinic in such a way that the patients who often travel from further away all see their doctors in a one-stop visit. So this program has been going on for a number of years now, and currently over 80 patients are enrolled in this follow-up program. We've had over 100 patient visits. Half of these patients actually require no action and they are clinically well and stable, but the other half all required additional treatment either by the pulmonologist, speech or language therapist, or actually required additional surgical interventions. So in conclusion, we feel that this patient group with laryngotracheal stenosis needs a multidisciplinary long-term follow-up program with attention for functional outcome, voice quality, and quality of life. And if we have, hopefully after running this program for a couple of years, we learn from our own long-term follow-up outcome, and we learn from our patients in order to optimize outcome in the future. Thank you for your attention. Here are the contact details should any questions arise.